So good morning. Welcome to Winship Grand Rounds, and it is my pleasure to introduce our speaker this morning, who comes all the way from Norway, Stavanger University Hospital. Dr. Emiel Janssen is a professor of biomedicine at the University of Stavanger. He is the head of the Laboratory of Molecular Biology and head of the research group from the Department of Pathology. He's published numerous articles and very high-impact publications. My interaction with Emiel and Håvard Swallen has been wonderful over the last 6 to 7 months as we've been collaborating on research grants and potential publications stemming from the Norwegian Prospective Breast Cancer Biobanking program, which they've cultivated for several years now across all of Norway. And so we're very interested and very enthusiastic about your ability to come here today. So thank you so much.
Good morning. Thank you so much for the introduction, and thank you for having me. It's a great honor for me to be here at the prestigious MAmmary Institute. It's really fantastic being here, very inspiring. So this morning I will try to wake you up gently by talking about our journey, not only building our biobank, but as well all the programs and the work packages that we've built around it. Unfortunately, my colleague, Professor Soyland, was supposed to be here. He's a breast surgeon, and he is the one that really started this biobank and started to work with this biobank as well. We're in a pretty amazing situation in Norway. It's a small country. Only 5.5 million inhabitants, but it's a very long stretch country. Up in the north, most people live along the coast, or the capital, Oslo, is over here. Communication by car is not that easy, especially in winter times. Most of the passages over the mountains are closed for 4 to 5 months. So that makes it as well that people do not migrate that much. They maybe, when they're a student, they go to other cities, they go abroad, but very often they come back to the city where they were born again. So it makes it very nice for population-based studies as well. All the Norwegians, and also all the immigrants into Norway, they got their personal identification number. We have a national cancer registry, we have a national medication registry, a national death registry, birth registry, etc., etc., etc. All these registries, once you have the ethical committee approval, you're able to combine all these things together. So that makes it really a unique population as well to look into cancer epidemiology. We're based over here in Stavanger, and we have then a collaboration with the next region north of us, that's the University of Bergen as well. So the whole biobank started actually at his PhD exam, that is Håvard Swallen, and Ernst Lien, Professor Ernst Lien from Bergen was his opponent, and from that moment on, it was in 2008, they started collaborating and really resulted in that we had the ethical approval to gather, collect material from breast cancer patients in this whole region here from that moment on. That was in 2010. So in Bergen, they have about 320 breast cancer patients each year. In Stavanger, we have 230. And currently, we have then 1,200 patients going through this program. And it's really a biobank program. It's not a clinical trial. The patients are all different therapies, but it is basically only a biobank program. We are looking at only patients with from T0, T1, and T2. As all the patients with T3 or 4, they enter in neoadjuvant treatment trials. So that's something different. This is what we do. It's very simple, basically, but it's very hard to achieve on the other side as well. So when patients come in, we ask their consent. If they come in for their diagnosis, afterwards they have a talk with one of our research assistants if they're willing to participate. And about 95% of all the patients that we ask are willing to participate, even though this is a conversation they have straight after that they had the diagnosis. And still it is well possible. And we have very few dropouts. So we have then, just before surgery, we draw blood, we get urine, and patients also respond to all these questionnaires. Afterwards, every 6 months, patients come in again. We draw blood, urine, and every year they answer the questionnaires once more. And we will do this for each patient at a period of 11 years. So it makes it fantastic for longitudinal studies, follow these patients along, treatment response, development of fatigue, side effects, etc., etc. Probably will spawn many, many different studies. From the blood, we have serum plasma, PBMCs, and as well we collect CDCs, exosomes, and platelets. And we do that then as every 6 months. And this is just an overview of all the questionnaires. This is just an overview of where our biobank is then very central. We have a study group and, of course, a scientific board, and all the different work packages where the biobanking itself and the financing of the biobanking is, of course, a major effort to keep it going. Luckily, both in Bergen and in Stavanger, our hospitals have noticed the quality of the biobank. They acknowledged the work that we've been doing the first couple of years. And now they're doing it as part of the infrastructure of the hospital itself. So we don't have to need external grants the whole time to keep this going. So this is really, really nice. I will talk you through to some of these work packages and some of the early results that we have already there. So just looking at the biobank in 2 different hospitals. Although the organization of these hospitals, and still Norwegian, is quite similar, there are some very specific differences as well. While in Stavanger we have these 3 lovely ladies doing an amazing job, Maria, Janne, and Siri, and they are the heart of the biobank. These are the ladies that see the patients every day, then call them in, call them back, and that's the success rate that we have, that it's so high. Of the 348 patients, we only have 8 dropouts. 8 patients said, no, I don't want to do it anymore. We have 26 that dropped the 6-month sample, but they come back for the yearly sample, at least. So this is really fantastic. While you look into Bergen, they have 900 patients recruited then, but they have 170 dropouts. There, the blood is being drawn at the central place. The central facility, close to the clinical chemistry laboratory, and patients go there. It's very impersonal. They see a different person every time and again, so it doesn't give the personal attention to the patient, and they don't get the personal attachment to the project itself, to the biobanking project itself. And our assistants in Stavanger really build up a personal band with these patients. And that's, for me, I think it's part of the success that we have in Stavanger. Some of the things that started it off, and Professor Lien in Bergen is one of the persons that really started it off, And he has been looking into tamoxifen and tamoxifen metabolism during his whole career. And thanks to this biobank, we really have to relive this project again, because tamoxifen is something we've been using for ages. So it's very hard to get financing to look into anything related to tamoxifen. It's old-fashioned, we know it, we can handle the side effects, that's it. But still, there are a lot of things that needs to be resolved, and especially as we now in Norway will be giving patients tamoxifen for 10 years. That's a long period of time if a patient doesn't have any effect of the drug in itself. So this is an overview of the metabolic pathway. It's adapted from a paper that we have with Timothy Lash. And you see here that tamoxifen, acetoindoxifen, they're the most important active metabolites of tamoxifen. And these metabolites, they have about 30 to 100 times higher affinity to estrogen receptor than tamoxifen itself. So it's quite important to know how much of these metabolites can you trace back in patients. And do they really have the metabolites? So there's been a lot of focus. Timothy Lash here from MAmmary as well. He has had a lot of focus on genotypes as well. So CYP2D6 is one of the important genotypes here. And you can then really categorize patients into 4 different metabolite types. So you have the ultra-rapid, and you have the very poor metabolizers. And there's been a lot of studies going on about really what is the value of genotypes in correlation with the outcome of patients. And as Professor Lass again has published as well, the results are really all over the scale. In the end, there's very little correlation. So the aim of our study was then to compare the prognostic value of CYP2D6 genotyping with direct measurements of active serum tamoxifen metabolites in operable breast cancer. And that's something we want to do later on in our Biobank project. With our collaboration with people in Oslo, we have a national network here for breast cancer research. Very open network, very easy to share data and material, where they have gathered material from 356 patients, all relapse-free at 3 years, with serum available. We had 99 patients. All these patients have had tamoxifen for 5 years, although the blood was drawn at 3 years. We measured 10 metabolites by LCMS, and we did a very extensive genotyping. And we compared these data with each other. So genotyping was done very extensively, collaboration with a group in Rotterdam. They do this for clinical diagnostics as well. And we measured then tamoxifen metabolites in serum. We've developed the measurement ourselves. You see here, it's very clear distinction that you can see the very active metabolites. And it's a very good sensitivity as well in this measurement. If you then look at the levels of these active metabolites that you see over here, and here you have the ultra metabolizers, and here the poor metabolizers, you can already see that there's quite some overlap between the different groups regarding the active metabolites. So maybe this is already then an explanation why genotyping is not that good for looking at breast cancer-related survival. If we do that and look at the survival, and of course there are very small groups here, you don't see that much. The effect is not clear from the genotyping. If we're looking then at the levels of the active metabolites, you can see that those patients that have very little metabolites of these two active forms, they do very poorly. And this is for a very long follow-up. It's up to 20 years. Of course, these are then cutoffs that have been chosen to optimize for this. One thing that we already discovered as well, that several of these patients did not have any measurable metabolites at all. So probably these were non-adherent patients. So these patients we selected out of these analyses. They're not in the same groups. If you do that in 3 groups, you see those that have a very high concentrations of these metabolites, they do very nicely. And here it's the same trend for overall survival. Of course, these are very small numbers. We need to validate it. Again, with the group of Oslo, we'll get material from 450 patients. We'll do exactly the same thing again and try to validate this. And if you look at the hazard ratios, they're quite astonishing. Of course, we have to look at these data as well. But if you adjust it for tumor size and age, grade, these active metabolites come out very strongly. Again, overlap, if you draw these cutoffs across these genotypes, it's clear that the genotypes have so much overlap, it's hard to use that for patient survival. And our explanation for this all is that if you have the genotypes, you have different phenotypes of the cause, looking at these genotypes. But of course, there's drug interaction, there's adherence, and you have the different other pathways. Well, we just look at the metabolite level, and that's really a functional readout of the genotype and all the things that are happening in the different pathways. And we think that it would be a much better way to look at these patients and to monitor patients during their treatment. So some conclusions. So CYP2D6 genotype is associated with concentration levels of active metabolites. The phenotype is not associated with breast cancer specific survival, and patients with low levels of active metabolites have significantly poorer breast cancer specific survival. And as I said, it's a small study, we need to validate it. In Bergen, we have a very specific study going on in adherence also. We selected 300 patients there. We will look at the National Norwegian Medication Registry. If patients really picked up their medications, there will be as well the questionnaires, if they're taking, about side effects and so on. And of course, in these patients, we'll also be measuring the metabolites to see, okay, what's really going on. But there's a study that's specific for Bergen. We in Stavanger are not that much involved in it. Another study is the personalized monitoring in breast cancer. That is really the thing we are looking for. It's a challenging biology of the patients. And it's really, yeah. So presently there is no monitoring of early systemic relapse in the follow-up care for breast cancer patients. And despite the knowledge that we have that distant metastatic lesions will eventually kill the patients, that if they should come clinically overt. We're not looking specifically for them. Just if there are clinical symptoms, then we go and look them. Before that, we don't have really good measurements to look and to trace these patients earlier. And so we want to find reliable biomarkers for early systemic relapse and thereby enabling to put these patients on an early secondary adjuvant treatment. Again, we're using this, our biobank material. We start with a really extensive DNA-RNA sequencing of the tumor. As I said, we are isolating circulating tumor cells, circulating tumor DNA, and we look at microRNAs in exosomes and tumor-educated platelets. And of course, once we have a patient develops a relapse, we go back again and say, okay, what's the earliest point that we can maybe have a signal from exosomes of the ctDNA that we can really use. So it's an observational study still. So far, we have then developed a protocol for isolation of these CTCs. Normally, CTC selection is done by using epithelial markers only. We have developed then Lapin et al. A selection that has a negative selection. So we select away those cells that we do not want to have. And by doing that, we end up with a fraction of course, there are PMBCs, but with most of the circulating tumor cells intact there. We've tested that with spike-in experiments, and if you spike in 1,000 tumor cells, we get 1,000 tumor cells back again. It's then in a fraction of total of 10,000 cells, but still we have these 1,000 tumor cells, we have them all, regardless if they're epithelial or mesenchymal cells. So that's a quite good thing. What we do then is a qPCR for specific epithelial and mesenchymal mRNAs that are expressed in tumor cells only. And by that way, we have a surrogate marker for the presence of circulating tumor cells. We've currently done that for 170 of the patients in these biobank. And from now until now, we found that 20% of all these patients are positive for CTCs. And we'll do this again longitudinally and look how it's going for these patients. We have a ctDNA protocol established where we're looking for specific tumor-related mutations. Of course, these mutations will be adapted to the mutations that you find in the primary tumor. But estrogen receptor mutation is, of course, one of the things we're looking at. And you can see here the panel of genes that we're looking at. So there are 150 hotspots there we're looking at. You only need 29 nanograms of DNA, and the limit of detection 0.1%. It's not the best, but with a 15,000 times coverage, you'll be pretty sure what you're looking at. So that will be very nice. RNA isolation has been started. We've now isolated the RNA for 125 high-risk patients, all luminal B patients. So they're ER-positive, Ki67 above 30%, and they're currently on chemotherapy. Results that we get there is that from the exosomes we get about 5 to 36 nanograms per microliter, and that's quite a good quantity to start with qPCR for specific microRNAs. We've done quite some studies in microRNAs in primary tumors, doing profiling, and I found several very interesting microRNAs will be continuously follow. And we have developed a protocol for platelet isolation and RNA from these platelets. And again, there as well, we're looking for specific microRNAs. For the DNA, we've chosen to look for the Oncomine comprehensive assay, where we're looking at 161 driver genes, while the RNA will be done by a total RNA sequencing kit. Because we have frozen tissue of these all as well. So what we want to do is, by looking at personalized treatment and the personalized follow-up, we want to develop a personalized monitoring as well for all these patients by doing all these techniques together. Another project that we've been doing is, and I must say as well, one of the things why everything works so well in Stavanger is the very close interaction between surgery, pathology, oncology. They're very closely located to each other. We've signed an agreement with each other that we will share all data, we share all the patients, we share all the material with each other in an open way. We put everything on the table and say, okay, what will we do? Which grants are we going to look for? Which studies are we going to do? How are the co-authors divided? Everything together. And as that, we stand very, very strongly, I think. And it makes as well that the communication lines between the departments are very easy. So if we want to design something, it goes very quickly through the system. And one of these things is this project as well. It's not easy to get. Again, one of our research assistants, together with a pathologist, are looking at the paracrine interaction. So you have, the idea is that you have the tumor in the middle with the microenvironment around it. And of course, we all know there's a lot of interactions going on there. But it's very difficult to investigate this because the most things that we do is make just a soup out of everything for the DNA sequencing, RNA sequencing, etc. But it's very hard to look into the tissue, what's really going on. There's a lack of material there. So what we're doing is, if you have the tumor over here, we'll be taking material by this, just making biopsies of the edge of the tumor, the transition from the tumor into the fatty surrounding tissue, and take several out from the tumor as well. And we try to take tissue as well as far away from the tumor. Of course, this is only possible if you have a very good communication with the pathologist, that the pathologists are sure that what's going on will not interfere with their diagnostic work, of course. So there's always a pathologist involved as well. But having these short communication lines, it's really possible. And of course, this is quite unique material. With this material, you want to do a molecular subtyping according to luminal A, B, and HER2. Can we do that by looking at the stroma as well? We, of course, want to look at the inflammation, not only by NGS, but of course just by pathology in itself as well. We have the frozen material, can make frozen slides and have a look there as well. And of course, we want to relate everything here with body mass index, and we will do some metabolomics as well. Metabolomics work, of course, we all know that is one of the key elements in cancer transition. Many of the tumor cells are addicted to glucose, and they will actively excrete lactate, acidifying as well the microenvironment of the tumors. So together with Tune Baten and one of our first research assistants again, maybe that's interesting as well to know, these research assistants are assisting in their own research projects as well. So they're not only drawing blood, but they're actively collaborating into these scientific studies as well. So it keeps it very interesting for them and keeps them as well inspired to continue this work. So there we look at metabolomics, both in serum, in urine, but also in tissue. They've developed a very interesting method in Trondheim, in the middle of Norway, where you'll be able to use fresh frozen tissue, look by MR, and we'll be able to do a really broad, get a metabolomic profile. We have no data on, from the Biobank yet. Last but not least, of course, this is also one of the reasons why we're here. For about a year ago, Professor Lass sent us an email. So, hi guys, how are you doing? We've been collaborating with Professor Lass since 2010, I think. Send us an email, hey guys, would you be interested in a project in fatigue? Here you have the contacts of these persons. could you have a look? Of course, we were very, very interested, and we were very flattered that persons from MAmmary would like to collaborate with us in little Stavanger, so that was very, very nice. We're still very flattered by it. And it's, of course, surrounding fatigue. So it affects up to 70% of all the breast cancer survivors. And about 30% of these patients will really suffer from fatigue in longer periods of time, and it can be really moderate to severe fatigue. And still there's a discussion going on, what is the cause of this fatigue? Is it due to inflammation? Is it depression? Is it sleep deprivation? What comes first? Is the depression first, and then comes the fatigue? Is it the fatigue that causes the depression, and so on? So what we have, of course, in these possibilities here is that we want to all get an improved survival for subgroups. And our new endpoints are then fatigue, quality of life, and of course as well socioeconomics and work life participations. When we talk to our user representatives or patient representatives, they said up to 70% of their patients do not go back actively into work. That's something the breast cancer registry in Norway is a number they have. There's very little data that confirms that. And we talk to our oncologists, they say, no, that person worked, according to them, is not really the same number. So that's also something really take into account now. We'll register that as well and see and get better numbers on that as well. Like I said, a year ago, we got the first email. Now, beginning of this year, Professor Torres and Professor Lash visited us here just in front, the closets with all the questionnaires that we gathered. Before the summer, we had not done anything with it. And now both Professor Soylens and my son, they've worked the whole summer, and now all the questionnaires are loaded into the database. So we're ready. So the whole collaboration starts based on the results from Professor Torres that she has been doing here at MAmmary, looking at fatigue, looking at childhood trauma, and epigenetics. So, like I told before, these are all the questionnaires that we have related to quality of life, functional assessment of cancer therapy, and medication adherence, and of course the fatigue scales. Again, an overview, quite a lot of work for the patients to go through all this, but again, with that personalized follow-up that the patients get, we really have a high number of patients filling in all these questionnaires. The hypotheses of the grant application that we've sent together with the groups from MAmmary is then, okay, if we have the breast cancer treatment, will it really correlate with a difference in the methylation pattern that we see in many different genes? Then the methylation pattern, will it cause a change in inflammatory pathways, and can we measure that as well, and how does that correlate with fatigue? It's a very ambitious project, very ambitious, but of course with these longitudinal data that we have, with all the questionnaires that we have, I think we have the power statistically as well, really, to get some really interesting answers over here. This is the whole PBCB study group. It's a very diverse group. Not only we have here Gunnar Melkren, he's an endocrinologist, a surgeon, radiologist, patient representatives, But we have also culture scientists who are looking at what the effect is of a mastectomy on women, not only from a perspective of the medical side, but as well a psychological side. I'm not the same as the project. The project that is a collaboration with MD Anderson. And of course, like I said, it's really a multidisciplinary group. People from Bergen, from Oslo, and of course the people here at Emory as well. If I could just talk you through another project as well that might be very interesting for you. It's another project, a neoadjuvant trial. It's called Personalized Treatment of High-Risk Mammary Cancer, the PETREMAC study. It's a study that is, the PI is oncologist in Bergen. There's a laboratory in Bergen as well, and in Stavanger we are the national pathology lab. There are 8 centers that participated throughout whole Norway, and this again gives you an overview of what we're able to do at this moment. It took quite a lot of time. There were a lot of political issues to start with. PIs that didn't want to collaborate with each other. But at this moment, the breast cancer researchers in Norway are very open and really open for collaboration with each other, because we really see now that this is the only way to go. We have to do this. We have to collaborate in these clinical trials with each other, because otherwise we're never able to get all the patients. But of course, it gives you some logistic problems as well, because the patients are treated locally. We are the central lab for the pathology, so all the biopsies have to be sent over to Stavanger, frozen material as well. And that took a lot of effort to really keep it going. But at this moment it's working. Even people that send it from here or here, within 2 weeks in Bergen, they will get the results from the diagnosis. They will notify the people in the local hospitals, see what kind of treatment should be started. It's a neoadjuvant study. It's in 200 patients with locally advanced breast cancer. And the primary aims are to identify novel predictive genetic markers for therapy response to improve breast cancer therapy. And you test whether known predictive markers, ER/PR, HER2, Ki67, and P53 can be used to provide the optimal individualized and targeted therapy to patients with breast cancer. A long list with objectives. I want to go through it due to time. This is the really upset of the whole study. With all the different arms, patients have the possibility. Where we draw blood, in Stavanger again, we'll look for CTCs beforehand. Will be a biopsy after 2 weeks. Again, we'll look at Ki67. In a very short time interval, of course, we'll look for Ki67. If there's a drop, patients will continue. If there's no drop, patients will go on to CDK4/6 inhibitors. Again, after treatment, again, we'll take a biopsy and draw blood. We will gather CTCs. And this is now a study that's open to accrual, and I think after 1 year we're up to 120 patients that are going through this whole program. We're responsible for the pathology and for isolation of the CTCs and the ctDNA. Of course, we will look for the microRNAs and proliferation. That's our main target in this project. That's all. I hope you got an impression what's going on. Thank you for your attention.